Special thanks to doctors presenting our cases this morning. First case was Dr. Mayra Ferreira from Marie Curie Hospital in Buenos Aires in Argentina. The second case will be from Dr. Zaida Moranti from INEN in Lima, Peru. And the third case will be from Dr. Pamela Selman from the Fundación Arturo López Perez in Santiago, Chile. I also want to special welcome and thanks to our standing panelists, which include myself, Dr. Paul Goss, Dr. Marcelo Del Carmen, Dr. Tom Randall, who are not here this morning, Dr. Don Nizon, Dr. Alejandra Rauhane, Dr. Mike Mura from MGH, Dr. Brittany Bershowski from Dana-Farber, Dr. Kathleen Schmiller, and Dr. Anuja Jingran from MD Anderson in Houston, Dr. Linus Chang from Mount Sinai Hospital in New York, Dr. Anna Turgis from Columbia University, New York, and Dr. Teresa Diaz-Montes from Mercy Medical Center in Baltimore, Maryland. Please keep your microphones on mute unless you're speaking, and the PowerPoint cases and the YouTube video of today's discussion will be archived online after the tumor board. All references or clinical trials cited in the tumor board will be sent to you after the meeting. And so with that introduction, I'd like to welcome you again, and can we please get started? Dr. Ferreira, can you present the first case, please?
Yes.
You just get to share the slides. That's our panelists, and there's a wonderful picture of Dr. Mayra Ferreira and her hospital. Please go ahead, Mayra.
Okay. 2 years old female, one pregnancy.
Start again. We missed the first sentence, please.
Okay, 32 years old female, one pregnancy, no family cancer history. She was referred with pathological pap smear and was an squamous carcinoma with parametrium positive, and the tumor size was 3 centimeters. She had negative extension studies. The diagnosis was squamous carcinoma E2B, and the treatment plan was neoadjuvant chemotherapy with paclitaxel, cisplatin, and fluoracil for 3 cycles. After the 3 chemotherapy, the tumor size was 1 centimeter, and the pelvic scan was negative parametriums. She was scheduled for 1 more chemotherapy cycle. And after that, radical hysterectomy. The pathology was squamous carcinoma in situ. The tumor size was 3 millimeters, and the uterus, ovaries, and parametrium free of lesion. And she had negative lymph node. So the question and exclusions are: after the neoadjuvant chemotherapy, the patient had to give response. And this is not a standard therapy, so we decided that because of the age of the patients. So we are wondering if we should next consider radiotherapy or continue an observation with the apparent control disease.
Thank you, Myra. So maybe we'll open it up for general comments about the case and then specific questions. So if anybody wants to say anything about this case. What is stage, for my education, what is stage E2B? What does that mean?
I'm not sure what the E stands for.
What does E stand for, Myra?
Sorry, what?
The squamous carcinoma E2B, or is that a typo? Should that be T2B? Where you have the diagnosis. You said it's squamous carcinoma E2B or T2B.
E. E the elephant.
What does that mean?
Is parameters positive?
Parameter positive. Do you recognize that staging?
No, I don't know what the E stands for, but I understand it's a 2B. I don't know what.
I think it means extra cervical spread or something.
No, that's why it's stage 2.
Oh, okay. The E is the stage.
Estadio in Spanish.
Sorry, we were confused.
Okay.
Yes.
Sorry, it's a Spanish-English thing. Okay. All right. We get it. Thank you.
So, I mean, I think, We have very little experience using neoadjuvant chemotherapy for cervical cancer in the U.S. It's not something we do routinely. My review of the literature the last time I looked, neoadjuvant chemotherapy is usually done to make a surgery feasible, as it was in this case, but it doesn't negate the importance of adjuvant treatment. So I do think she should get radiation therapy still, but I'd be interested in Anuja's input on that. I mean, in general, what I've read about folks who got neoadjuvant chemotherapy, they're often offered chemotherapy after surgery, but that just seems to be what's done in Asia as well as in Latin America. I know that there has not been a really great trial about this.
Yeah, I think I agree with Don. I don't think we rarely. I mean, I've never used neoadjuvant chemotherapy here. My understanding, there are right now 2 randomized controlled trials underway, international trials, and at some point we'll have some information about the role of neoadjuvant chemotherapy. But I agree with Don. I think in this case I would feel uncomfortable not offering radiation, but I think Anuj is the best person to even talk about that.
Yeah, so I've actually looked at all this literature, and I've actually, kind of like looked at what the data is. So again, in America, we don't use neoadjuvant chemotherapy, so we don't have a lot of experience. Now, key thing I think to remember in this case is that this is a clinical stage, right? So did she really truly have 2B disease? And that's really just by the exam. So there's no documentation otherwise saying whether it was 2B or not. And if you look at her post-op, she only had in situ with 3 millimeters. I'm not sure. And if you look at the data, whether you should add radiation therapy or not. And in most of the data, they probably would not add radiation therapy. The literature, though, unfortunately, if you look at the old historical data, 2 of the cases from the meta-analysis had all the patients receiving radiation therapy. So it's unclear. I personally would observe this patient because I'm not sure she really truly had 2B disease or whether she just really had a 3cm tumor, which actually would be a perfect candidate for neoadjuvant chemotherapy followed by hysterectomy. The EORTC has a trial that just finished, and hopefully those studies will come up in a year or 2. It finished accruing about 2 years ago. So my thought is I would just observe her. That's just my thought. Because it's truly a clinical staging. You don't really know if she really had 2B disease.
Well, Anuja, I mean, I think, but if you assume that the stage is correct, if you were sure she had 2B disease, would that influence your decision on whether or not to radiate?
Well, she had a parameter.
Well, that she's saying it's clinical stage, so she's unclear.
Okay.
What if you were sure it was a 2B?
If I was sure it was a 2B, I would then probably add, but there's no data that shows one way or the other, right? The data that we have is from the post-operative specimens, and you add the radiation depending on what is residual after the neoadjuvant chemotherapy.
Well, that's different from breast, and I know when you give neoadjuvant therapy for breast, Paul, you want to comment on that?
I want to begin a discussion that I'm extrapolating from breast to gynae and see if it applies.
Yeah.
We have discovered in our research that most South American countries, the biggest difference in causing mortality is a clinical upstaging of stage 3 and 4 versus 1 and 2 in the United States. So the single biggest reason for the mortality being so much higher is a greater upstaging. Now, in that path of diagnosis to treatment, one problem we've identified in breast is a very lengthy delay between pathological diagnosis and the institution of surgery. Because of weight on the surgical unit and busyness, they don't often able to schedule like we do within a week or 2. So, in breast, a trial has been done where adjuvant chemotherapy has been given neoadjuvantly versus adjuvantly by the NSABP, and no difference in outcome and survival has been shown. So, that has resulted in breast cancer. If a patient has a pathological diagnosis of breast cancer, and you know that the patient is going to require adjuvant chemotherapy, so you can clinically stage or radiologically stage 2, 3, or 4, for instance, then people will sometimes start the cycles of chemotherapy adjuvantly, neoadjuvantly, and just interrupt it at the right time for surgery and then complete it off. So if it's 4 or 5 or 6. Is that something that could be done or should be done or would be done for cervix cancer? That's staging with peri-aortic nodes or stage 3 or 2B?
Well, I mean, that's been the practice, I think, outside of the U.S.
Yeah.
Of sort of getting people treated urgently because they tend to have more locally advanced disease.
Okay.
I think the dilemma now, and Anuja and I are sort of, and Ali are sort of grappling with it, is what do you do with the pathological response in someone who first presented with advanced disease?
Right.
So, breast, for example, the role of radiation therapy depends on what patients presented with, not the pathologic response. So, someone who had a T4 breast lesion who had an incredible response to neoadjuvant chemotherapy will still get comprehensive breast radiation, even if there was a pathologic CR. So I think that's sort of what has been the experience in the breast world. In cervix, it's a little bit more difficult. Like Anuja, I think I agree with you. Sort of, it's not technically neoadjuvant therapy the way we think about it a la breast. You give some therapy up front, then you give some therapy at the back end. So if you weren't going to radiate this patient, I probably would commit her to 3 more cycles of chemo just to complete it.
Yeah, I mean, there's really no data, so you could do it either or. If you really truly believe it's a 2B, I think I'd be more comfortable in giving radiation. I'm a little bit concerned with a 3cm tumor that has such an amazing response, whether she really had true 2B disease. But I agree. Either, if you truly believe it's a 2B, she needs some sort of therapy, whether it's radiation or chemo.
Yeah, and I think most of us would agree it would be radiation rather than chemo.
Yeah.
But it doesn't negate. I guess the pathological response shouldn't negate the adjuvant treatment paradigm at this point. I mean, the neoadjuvant data is just not that clear.
So maybe I should also add that in June and July, I have 2 new fellows joining me from Brazil, one from Belo Horizonte and one from Rio de Janeiro. And at the request of my colleagues at Mass General, we want to start a global database, as we've done in breast cancer. We want to start a global database looking at the outcome of patients with neoadjuvant chemotherapy. Because stage 3 and 4 cervix cancer is so rare now, thank God, in the United States, our doctors are losing the opportunity and experience to treat those patients, which you sometimes see, but not often, if I'm not wrong, and also to do clinical trials. So advanced cervix cancer is not a US disease, as a rule, but it is very common. In South America, we see patients presented on these tumor boards and in the literature with stage 3 and 4 disease. So neoadjuvant chemotherapy is of great interest to our expert doctors in the United States, but they don't give it. So they have no experience, and they can't do clinical trials of new regimens or new strategies. So it is up to our global colleagues in South America to help us study and to let US doctors participate in clinical trials occasionally, but to lead the charge on advanced cervix cancer until we get it under control better. So that's one thing I wanted to tell you about coming in June and July. We're going to start building, in collaboration with our gynecologists, we're going to start building an important database.
Hey, Paul, can you just see how many people, so you've got a good audience of South American and Central Americans who do a lot of neoadjuvant. Can they raise their hand? How many would give for adjuvant therapy? Maybe interesting to see what our audience would say. Can you ask that question?
Well, you ask it. So if our doctors could respond to Dr. Gingran, please, for this question. Go ahead, Anuja, ask the question, please.
How many people would give adjuvant radiation therapy for this patient from our audience?
Can you just raise your hand in South America if you would give adjuvant radiation? Just put your hand right up in the air so we can see you.
Or also type into the chat.
Or type into the chat box for viewers, please. Would you give this patient post-operative
Radiation therapy.
Who would give radiation? So am I to take it? I don't see any hands or any comments.
Eduardo from Brazil says yes, he would.
So Eduardo from Brazil says he would, from Inca in Brazil. Eduardo Paulino, who's one of the doctors joining us.
Argentina would. Okay.
We decided to make the radiotherapy.
Okay.
Thank you.
Thank you.
So it's not 100%, but it's not nobody.
Right.
That's the answer, yeah.
Yeah.
And there's a lot of people answering by typing in their answers to say that they would give it. So
Okay.
there is a diversity of opinion around this topic, as we have discussed. So that was a very great question, Myra. Thank you for that case. And perhaps we can move on to our second case from Dr. Zaida Moranti from Lima in Peru. Dr. Moranti, can you go ahead and present your case, please? We'll just show the slides. Okay, there's the case. There's Dr. Moranti from Inan, and here's the case. Can you start presenting, please?
Hello, good morning. This case is about a 38 years old Hispanic woman, menarche at age 13, no family history of cancer, with history of 2 years of intermittent vaginal bleeding associated with chronic pelvic pain of moderate intensity. In the gynecological examination, we found an 8 centimeters ulcerated cervical mass. Parametrium was involved. She underwent a cervical biopsy that showed a poorly differentiated squamous cell carcinoma associated with high-grade neuroendocrine carcinoma. Pankeratin positive, synaptophysin positive, and Ki-67, 84% for both components. In the abdominal pelvic CT, we can find cervical malignancy with extension to the lower third of the vagina, positive lymph nodes in the common iliac and the retroperitoneal area. The final diagnosis was stage 3B cervical cancer. On December 2015, she received concurrent chemoradiation with carboplatin plus etoposide and radiotherapy in pelvic fields. But radiotherapy was suspended after 15 sessions because she developed hematological toxicities. And then she continued chemotherapy until complete 5 cycles of cisplatin plus etoposide and achieved a partial response. She underwent radical hysterectomy with pelvic lymphadenectomy, and the pathological anatomy reports chronic cervicitis, uterus no malignant neoplasm, and pelvic lymph nodes 1 of 24, pankeratin positive. Our first question, in light of surgical findings, should these patients begin follow-up? And the other question, considering an epidermoid component of the tumor, should this patient complete radiotherapy?
Okay. There are the questions.
Can you help me understand why the original decision was to give carboplatin with etoposide if you were planning to give radiation therapy?
The doctors considered, yes, the toxicity and the neuroendocrine component of the tumor, and because of that, they begin with carboplatin etoposide.
I think Don raised a good point there. I mean, all of this is extrapolated from lung cancer. I think most people would treat initially with cisplatin and etoposide. I think if you have a lot of toxicities, I mean, if the patient has like poor renal function, then you can switch to carbo. But I think a lot of people maybe would have started with cisplatin right away. I think that's a minor point.
Don?
And well, I just think particularly with, if you're giving, and Anuja, I'd be interested in your thoughts on this too. If you're going to give radiation therapy, we know that you can do it with cis. I think with carboplatin, especially if you're combining with a second agent, I think it's not surprising she had hematologic toxicities, and I would be concerned about basically not completing the radiation therapy as part of her original plan.
I totally agree. We do use we do cis and etoposide for neuroendocrine tumors with our pelvic radiation therapy, and but we do use a lower dose of etoposide. So I need to get that to you guys. We don't use 100 milligrams. I can't remember what dose we use, but we do use a lower dose. My other concern is that she had parodic nodes, and the parodic nodes were not treated. Do you know what happened with it? I mean, did she truly have parodic nodes originally? Because it said she had common iliac nodes and retroperitoneal nodes as well.
That's what it says. On the abdo-pelvic CT, it says positive lymph nodes in the common iliac and retroperitoneal area. So you're quite right, Anuja. And
they were never addressed either because they did a radical hysterectomy and pelvic node dissection. They didn't do a parodic node dissection. So I guess that, that's the other question is what happened with the parodics.
So would you like to answer that from Inan? Because there's a concern here about untreated para-aortic nodes positive on the CAT scan. Your opinion about that from Inan, please.
Hello. We have another abdominal pelvic CT of this week, and we don't have any lymph nodes positives in the last abdominal pelvic CT.
Right. Anuja, the answer is they appear to have clinically or radiologically resolved. Does that satisfy you or not?
I personally think this patient probably needs more chemo. Don, what do you think?
Well,
I think it's too late to come back with the radiation.
Yeah, I mean, if you look at what it took for her to get to the point of surgery, and she still had residual node-positive disease at the time of surgery, she's going to be at risk of having a relapse or metastatic disease. So I do think, again, it's I guess the dogma at this point, until it's better defined, is whatever it took to get her to surgery doesn't really matter when you're going to make adjuvant decisions in cervix cancer.
Right.
So in this patient, you have node-positive disease, even if there is a pathological complete response in the uterus, including the cervix. Her prognosis is going to be determined by the fact, A, it's neuroendocrine, and B, she still has disease.
Exactly.
So, I mean, I think she warrants something else.
Yeah, and the other thing is that I think one of the questions is whether if the surgery added any survival benefit to these patients.
Yeah.
I don't really know. I think, I would be very worried about, neuroendocrines have poor prognosis just by histology, and I just don't know in these situations whether surgery for like advanced stage neuroendocrine adds any benefit. Certainly, if someone has stage 1 and you give chemotherapy and then surgery, that in retrospect the series have shown to be a benefit. I just don't know in advanced stage neuroendocrine tumor where the surgery had any.
So, Alejandra, would you just summarize how you would have perhaps treated this patient?
I think I think what we have done here was give chemotherapy, cis and etoposide, assess response. I think at some point we'd have done some kind of imaging, probably a PET-CT, to see whether she responded very well and to assess the prioritics. If she had residual disease after chemotherapy and radiation, I think that's a kind of patient that even if you know that you take to the OR, I just don't think that you're going to be able to prolong survival if they start persistent disease after chemo rats.
So you wouldn't take her to the OR?
I mean, if she had persistent disease after chemo rats and it's in the prioritics and the pelvics, I would have had time believing that was going to be cured.
Well, it seems, just kind of reading back, and I'd be interested in your opinion, because you guys are the ones actually treating her. Was the original plan to even do the surgery? Because it's interesting that what you delivered was definitive chemotherapy. We had to halt the radiation, but normally I think we would have done maybe 3 cycles, reassess, and if there's a window for surgery, do it then. So I guess the first question is, was there an original plan to do surgery in this patient at all?
Yes, we were trying to get to the surgical option to this patient.
Okay. Yeah, I mean, the hard part now in the adjuvant setting, and I do think, I agree with Anuja that I think she needs further treatment. I don't know what you would possibly give her. She's gotten 6 cycles of cisplatin and etoposide already, and there is still residual disease. That makes me worry that the same is probably not going to be effective.
Is this patient, for my benefit, is this patient's whole case being driven by the
node.
by the neuroendocrine
Yeah.
pathology
And the node.
and the node? Yeah.
The persistent node after 6 cycles of platinum is concerning.
Yeah, so couple of things at MD Anderson, we would have, she would have probably gotten a little bit different than what you would have. We would have done weekly cyst. We would have treated extended field because of the positive parodic nodes. And definitively with chemo radiation, and then we would have followed this with either carboplatin and Taxol or cisplatin and etoposide because we don't know which drug is better, even though we think cis and etoposide is better. I'm worried that this lady is going to have high risk for distant metastases, and I mean, I don't know, Don, what do you think about doing Taxol? Because that's what she hasn't seen.
Yeah, I mean, I was thinking of Taxol as well. I think it's going to be important that you restage her after the surgery and include the chest in that before you embark on an adjuvant treatment.
After the surgery she's had,
just
not further
now.
surgery,
Yeah.
right? You're not recommending peri-aortic surgery.
No. I think at this point you just want to assess and make sure that there isn't any metastatic disease that has developed in the interim. Yeah, I mean, I guess you could do Taxol alone. I guess I'm also leaning towards maybe carboplatin with Taxol at this point. And 3 cycles. So which is sort of, it's building on sort of the Duenas-Gonzalez trial where you gave it. But what do you think about radiation therapy post-op?
Well, the problem is that she's already gotten, she got some radiation, and now we're so far away from it, and to give any dose that would be meaningful, it's too late. How do we add it after she's gotten something, and now we're 6 months later?
Yeah.
Right? The question is, could you deliver a dose that was meaningful now? Probably not.
Yeah, and to what field?
Right, exactly.
Yeah, so maybe I think it would be better part of valor, give her 3 cycles of carboplatin and Taxol in the adjuvant setting, and then follow her very closely. What do you think?
Sure. I mean, I think she has a poor prognosis. To be honest with you, I don't think there is right or wrong answer in this situation. I think if the question is whether to give more treatment, I would definitely give her more treatment. What treatment? Carbotaxol sounds reasonable.
Yeah, at this point you're treating with the intent of cure, so you might as well finish that pathway and then observe.
Yeah, and I will definitely send you the doses that we're using with cis and etoposide, because we definitely use a lower dose of etoposide, which may have made it easier. And I think cis is also, we give a little bit lower dose. It's a Memorial Sloan Kettering regimen with the radiation that is actually very feasible.
Can I just say that, would it be common in the United States for a woman to have intermittent vaginal bleeding for 2 years with pain before she seeks medical attention? This patient presents with an 8 centimeter. That's a very large tumor already clinically. And I think that was the problem in this case, is that she didn't get medical attention earlier and biopsies earlier. I think, unfortunately, it's an awareness, a public awareness issue or an education issue, but this patient obviously sat on 2 years of intermittent vaginal bleeding and pelvic pain before she went for attention, and showed up with an 8 centimeter mass in her cervix. So if one really were to rewrite this case, my prayer would be for an earlier intervention and diagnosis at a lower stage. I think she's unfortunately, unwittingly allowed herself to get into rather a fatal prognosis situation by delaying for 2 years. That's my view of this. And I'm sure this is something you see very often, and this is exactly why it's less common in the United States for us to see this advanced stage of disease, because it's uncommon for a patient to go 2 years with vaginal bleeding and pain before seeking medical attention. Anyway, be it as it may. Does that answer the case? It's a very difficult case, so thank you, Dr. Moranti. Dr. Salmon, are you there for the third case, please? We'd like you to present the third case. Are you there in Santiago?
Your microphone is
Just
on
turn
mute,
the
Dr.
microphone
Salmon.
on, please. Hi, can you turn your microphone on? Yeah, that's better. Can you hear us now? Just turn it on. You had it on a minute ago, and then you turned it off again. That's it, that's it. Can you say something?
Yes, I'm here. Can you hear me?
Yes, we
Can you hear me?
We can,
Yes.
thank you very much. Okay, Dr. Salmon, could you go ahead and present your case from Santiago, please?
Okay, this is a 56-year-old female with no relevant comorbidities. She was a very healthy woman, but as many of our patients come in very late, she came in 2012 with an increased abdominal size, bloating, abdominal pain. She was and she had been for a year with with vaginal bleeding. She had weight loss and an ECOG that went up to 2. In the physical examination, she had ascites, a pleural effusion. We didn't and her gynecology exam viewed an enlarged uterus with vaginal involvement. Their images at that time, the CT of the chest showed left supraclavicular lymph nodes, the pleural effusion, the periaortic and mediastinal lymph nodes, and the abdominal and pelvis CT showed a large mass associated with her uterus, multiple lymph nodes in the retroperitoneum and the pelvic areas, ascites, and invasion of the peritoneum surrounded the uterus, the rectum, and all the pelvic area. Her colonoscopy was normal, and her CA 125 was 485. The biopsy that was performed showed a solid carcinoma with clear cell component, and everybody diagnosed at that moment and thought that it was of the cervix. So we decided to go on with chemo, and we started chemotherapy, carboplatin and paclitaxel, and we went in on doing 6 cycles of this, and the images in the imaging post the 3 cycles and after the 6 cycles only showed a small mass in the uterus. She had a great effective response to the chemotherapy. And her CA 125 went down to 14. So the surgeons decided they wanted to see what was going on, and finally, after performing a laparoscopy, they saw that there was no carcinomatosis, so they went on and performing a total hysterectomy with bilateral annexectomy, and the biopsy showed that this was not a cervix carcinoma, but it was an adenocarcinoma of the endometrium. It was an endometrioid adenocarcinoma, grade 3, with myometrial involvement and infiltration of both ovaries. So she went on with no more treatment. She was just on observation, and on 2015, her images showed that there was a pelvic mass and, again, a supraclavicular lymph node. The CT scan showed iliac lymph node involvement and a 5-centimeter pelvic mass. And her CA 125 went up again to 265. So we challenged the chemotherapy, again, the same scheme, and she went on with 2 cycles of that, but she had now clinical and radiological progression. So the questions are, what other treatments can we offer this patient? If there's a second and a third line chemotherapy for this endometrial carcinoma, and if there's a role for the radiotherapy.
And dare I say, a role for palliative therapy as well. This is the type of patient, this is a different topic that I'll cover in another tumor board, but there's been a large increase in palliative services over the past 2 years in South America. There's also been the introduction of signed patient directives for end-of-life care legislatively in many countries, led by Mexico, I think, first in the continent. But there's a very low utilization of palliative services and signing of patient directives by patients. So this is something that's radically different from the United States. This is the kind of patient who will probably show up in an emergency room and slow down the pace of clinic use resources and beds and things for her care, which could be avoided perhaps by involving palliative care earlier. But I'm interested in general comments from Dr. Dizon, first of all.
Yeah, just I guess the biggest question I have is, what was the rationale to proceed with hysterectomy in this patient?
Well, the surgeons wanted to see how much involvement was there, and that there was no carcinomatosis, so they decided to go on and do the surgery, the total hysterectomy, because they saw very little disease that was left over after the chemo.
But there was no biopsies ever done of the supraclavicular nodes that she presented with in 2012 to prove stage 4?
Yes, absolutely. But she had a complete response. As images worth-wise, she had a complete response everywhere.
Wait, no, but you had so you did biopsy the nodes in the supraclav?
At the beginning,
Yeah.
Yes.
Oh, and it was proven to be.
And it was positive.
Ah, okay.
There
Yeah.
was a yes.
Okay.
Say what's on your mind. Say what's on your
No,
mind.
I think I agree completely with the treatment that she has received so far. I think, to me, if she had a beautiful response to chemotherapy after 6 cycles, I have no problem taking her back to the OR and do a hysterectomy and a BSL.
For what purpose? What is your intent of the surgery?
I don't think there's any paradigm that shows any benefit here. I think it just to me, I would offer her surgery, no doubt, if she has a nice response. And I'm extrapolating a fair amount from ovarian cancer.
You're extrapolating hugely from ovarian
But I
cancer.
would just say that. Just 1 second.
I would
just
offer her
say,
surgery.
You would not be able to even justify that on the boards.
when I worked in Toronto, there were patients operated on with diagnosis of stage 4 cancer for 20, 30 years, right, for many decades, and it was finally abandoned. We used to refer to this as heroic surgery. It has no
But there was no
hope
hero. Yeah, but there
of
was no.
curative intent.
I mean, she got. I would say that. She got. Stage 4 endometrial cancer has a horrible prognosis, right? This patient had 2 extra years of life without cancer.
And you think it's because of the surgery?
I don't know if it's chemotherapy or surgery or the combination of both. There's no way to know.
But are stage 4 endometrial cancer patients ever cured with chemotherapy?
I
No,
don't think so. I think all of them have poor prognosis.
they're not cured with surgery either.
No. I'm not saying that she's going to be cured.
Then
I'm
what's
just
the
saying that you have
intent
to
of
look
doing
at
a surgery? So this one presented with supraclavicular nodal involvement from carcinoma, had a phenomenal response to chemotherapy. The role for surgery of removing the uterus is what? Curative, palliative, control?
Yeah.
None of the above. There was no reason to do surgery.
I think. Can I talk now?
Yeah.
I think it's for curative intent.
Oh,
that's what
really?
you're hoping.
Stage 4 was supraclav nodes.
That's what you're hoping. Again, that I would still offer her surgery despite Don's
But I think
disagreement. That's my personal opinion.
I just think that this is a critical question in solid tumor malignancies, and we have to come down one side.
You're not listening to the biology.
The surgeons do this
All
still
the
today in breast cancer,
Yeah.
and there has never been shown an advantage of surgery
Ever.
other than for local palliative reasons. If the patient has a fungating breast tumor, a bleeding pelvic bleeding or severe pelvic pain, fine. But no way can you ever convince me. There is not a shred of literature to suggest that you can cure a patient with stage 4 disease surgically. None whatsoever.
And
so you
also,
have to have an intent.
Well, not only that, you did a THBSO in this patient.
I'm gonna have it over back at the end, couple of weeks.
Well, no, but my point is, you had a THBSO in this patient who also had nodes throughout the entire abdominal cavity.
Well, she had a response, right?
I know, but you wouldn't even bother to sample the nodes.
Yeah, absolutely.
Did you sample the nodes?
No, they did not sample the nodes.
Then I don't understand the intent of surgery. I think that's what but here's the point, in the United States, this would be the discussion of this case even in our tumor board. Yeah. People saying you should absolutely do surgery, some of us saying I don't understand the intent of the surgery, and you're talking about a palliative procedure, the woman has
So we
stage
don't
4
have an
cancer.
Intercontinental difference.
It's a complete,
we have an interdisciplinary difference.
Yeah, oh yeah, yeah.
And I think medical oncologists, you say what?
And we've always got a radiation oncologist to like broker the.
I'm just gonna say at MD Anderson, at MD Anderson we would have done the surgery as well, and it is based on the ovarian data. So
but cervix is so different.
I don't agree with it.
Oh my God!
Would have gotten surgery as well.
You didn't even know it at the time. It was cervix. That's why they did the surgery, not uterine.
I know, but I have to say at MD Anderson that would have been, even though there is no data, and I totally agree, but it is based on the ovarian data where the debulking is important.
See, you can extrapolate from ovary to endometrial, because I do think stage 4 endometrial with carcinomatosis, we do see some of those women cured.
Yeah.
With an aggressive surgical approach and chemotherapy, you can cure but this wasn't endometrial. You did the surgery for stage 4 cervical cancer.
Yeah, that's what we thought. We thought it was cervical.
So if they thought it was cervical cancer, I would never have done the surgery. If they had, that's the truth. I think Don has a point there.
That's true. I agree.
If my thought was a cervical cancer, I would never have done a surgery. If I had,
that's the point.
Okay.
Sorry, that's all.
If I thought that there was concern whether there was endometrial, I would definitely have offered a surgery. But yeah, you're absolutely right. If it's cervical, then there's no role for surgery.
Yeah. Right?
I think that's a good point. I agree.
Yeah, so all of us are starting to say, endometrial, we do apply an ovarian cancer algorithm with advanced endometrial. I am more comfortable with someone who has uterine cancer and carcinomatosis going to surgery than getting chemotherapy alone. This is not endometrial cancer. At least you didn't think it was endometrial cancer when you started, and you guys did surgery for stage 4 cervix cancer. That's a totally different thing.
Yes, absolutely.
Brittany, you haven't said anything. You want to make a comment?
Sorry, I joined late today, but I agree. I think I'm a medical oncologist too, and I think probably my opinion would align with Dawn's in regards to the fact that I think this patient with stage 4 cervical cancer probably shouldn't have had a surgery. It'd be one thing if there was an indication where she was having severe abdominal pain, or if they were trying to control bleeding and they couldn't do radiation, but that wasn't the situation. It sounds like she wasn't very symptomatic and she was doing well after chemotherapy. That I think I think here we probably would not have done surgery.
Does chemotherapy prolong survival?
For cervical cancer?
Either endometrial or cervical.
Well, we do. Yes.
Okay.
Yes, it does. I think for metastatic disease, compared to historical controls, chemotherapy does have a role in prolonging survival. That's in the first-line setting, like most solid tumors. So first line, you have a bigger benefit than second, third, and fourth-line therapies. But we tend to continue to give treatments with the hope that we're extending survival. The problem with endometrial, and for the large extent in cervical cancer, after you progress on one line of therapy, median survival across the board for any drug you give is less than a year.
Yeah.
And that's based on phase 2 trials, really. And the attempts at getting a U.S. approval for a second-line agent, say after platinum taxane in endometrial cancer, I can think of 2 randomized trials, both of which were negative. for a new agent.
And
One
sorry,
was
just-
ixabeplone versus
Yeah,
ADM.
just to go back to non-sexy chemotherapy interventions, I'm intrigued by the literature showing that ambulatory palliative care for patients with end-stage cancer improves survival a little bit. So there, I think for a resource-constrained environment, an aggressive move towards palliative services and ambulatory palliative services is a mandatory part of stage 4 solid tumor malignancy and should be focused on a lot, I think.
Yes.
Because it would free resources to treat earlier stage disease better, you know.
Yeah, I think this is I completely agree. I think this is a case that this is a patient that you know that you're not going to be able to cure, and chemotherapy, the response rates in chemotherapy in someone with recurrence endometrial cancer after going through a second line of carbotaxol, I mean, there's very limited data. I mean, I would offer her a single agent, has low toxicity. I would think about Doxil. I think the response rates with Doxil in this setting is 8 to 10%. So. But that's an agent that has low toxicity, it's easy to administer, and other than that, you know, I don't see any other, you know, you can use single agent Taxol, but she already kind of progressed through Taxol.
Yeah.
So.
Yeah, so an anthracycline, like Ali mentioned, would be probably our second, is what we would offer her now. If I needed the response, I'd use adriamycin rather than Doxil, but if she was doing okay, and didn't have a lot of symptoms, I think Doxil does make a lot of sense, and it's better tolerated than adriamycin. It can keep things stable, not as high of a response rate perhaps, but again, this is not a curative situation. And if she did maybe 6 months of adriamycin or Doxil and then had progression, I would probably try Taxol again. If she got it weekly, then try the every 3-week dose.
And I think the other question about radiation, I'll let Anusha respond to that, but my sense that it's probably with widespread metastasis, there is little role for radiation, especially with, you know, she has multiple sites of metastasis.
I'm sorry, I didn't get that.
So with multiple sites of metastasis, if she has like a lymph node, pulse the pelvic mass, I don't think radiation, I don't think radiation has a role, but I let Anusha respond to that.
I think it's only palliative. I totally 100% agree. I would, if she needs palliative radiation, I would do it, but otherwise, I agree. She does not have a role for radiation right now. Definitive.
So Anusha, you know, at the here in Boston, it's becoming more frequent that our preferred second line choice is Taxol Avastin, and we're using that quite frequently on our patients here. And it's, you know, it's producing disease control. That we don't have any phase 2 data saying how durable the response is. But what are you guys using second line over there? You know?
I know it's Bev, but I don't know if it's with Taxol, if it is with something else, but I can find out, Don, and I can email you.
Okay.
I know we're using Bev.
I did a calculation on the back of an envelope, but for something like a 2.4 month or 2.5 month prolongation of survival, it costs about $100,000, for which you could do about 100,000 Pap smears.
Yes.
So I think for a resource-constrained environment, the use of Avastin in cervix cancer is really not fully justified.
Right, and I totally agree with that. It's hard to justify here in the U.S. even, but you know, where it's accessed, that tends to be our go-to in the second line.
Well, Dr. Salmon, you've managed to do what I hoped with tumor boards. You've created a fist fight in Boston and I'm sure across the world. This was a great case, so thank you very much.
Thank you. Thank you.
Thank you very much. Does anybody have any other additional comments about the cases? If not, I'm going to thank everybody and say goodbye to everybody. Thank you very much indeed for joining the tumor board today. Thank you. We're a little bit early, but I think they were good cases. Thank you very much. Bye now. Thank you for joining. Thank you. Bye.
Hopefully they come back.